This is my case number 652 that I treated. 5 months after treatment, it failed and was extracted and examined by Dr. Carr. Perhaps we can learn from this failure. The preoperative X-ray and CT shows a large, well-demarcated radiolucency. Periodontal status was normal. There was no response to CO2 ice test. Symptoms revealed very slight tenderness to bite, palpation, and percussion. Mobility was normal. Patient is a heavy clencher with multiple abfractions and extensive mandibular tori. Therefore, I decided to treat this tooth endodontically through the PFM crown. I was concerned with the large size and possibly cystic organization. Endodontic treatment was done. The pulp was necrotic upon entry. There was a single canal, and I apically gauged with using a GT hand file to 20 MAF and a 1/0 taper. We irrigated with bleach and EDTA using the endo activator. The sealer used was Kerr Extended Working Time Sealer. Since I was concerned with large radiographic apical finding, I recommended 6-month follow-up with a CT scan. A 5-month recall was done with chief complaint of palpation, tenderness, and slight pressure sensitivity. Plus, there was a sinus tract. Sinus tract was traced to apex with GP cone. CBCT revealed significant lateral bone loss with very little change in apical lucency. Since the CT scan shows rapid buccal and lateral bone loss, and given those findings, I suspected probable root fracture and recommended extraction with implant.
When I got the tooth, I didn't see a vertical root fracture. I sectioned it sagittally, as is our method, and got a pretty good look at the root. Got 2 fairly good sagittal sections, not perfect, but enough to examine the canal. I was able to tease the gutta percha out. So after they were dehydrated and dried, these are what the specimens, the 2 halves, look like. And we're going to examine them in several areas. These are what the sputter-coated sections look like, and I urge you to go to the site and try to compare these and correlate both the wet, dry, and sputter-coated sections and see if you can actually detect where we're actually looking. We're going to look basically in 2 areas today, one near the terminus on side B and one near the orifice, more coronally in the orifice opening. So the 2 sections, area 2 will be right near the terminus, and area 3 will be up near the orifice level where there's a clean dentinal wall. So when you go into the site, go into the stitched images, and I'll kind of walk you through that. We're going to look right at area 2, right at the terminus of the canal, and I've outlined the stitched area there so you get a pretty good sense of where the stitching occurs. I think this is some of the best stitching I've done since we started this technique. So that's the area of interest that we're going to look at. And when you actually go into the stitched image and zoom in on it and look around, you can see a fairly extensive biofilm present, some demineralization of the mineralized front, but a lot of biofilm matrix present, and what appears to be suggestive of a candida, fairly heavy candida infection. And so it's worthwhile taking some time and using the stitched image and really take a look around and see what you can detect. I see a lot of biofilm matrix as well as some demineralizing smear layer and demineralizing mineralized layers. So it's clear that Dr. Endo did use some EDTA in this case as well. But when you go into it, you can see what appears to be candida-like organisms on the mineralization front, with still quite a bit of matrix. And when you go in and look at, I've included some of the literature on candida infections on the scan electron microscopy of candida infections to give you a better sense of what they look like from other authors. And they have a fairly characteristic appearance, although they're very pleomorphic and capable of many, many different kinds of shapes and sizes. So when you go in and you look, it seems to me there's quite an extensive candida-like infection at the terminus. Now, when you go up into the area 3, up near the orifice, the picture changes dramatically, and you can find no candida-like organisms there at all. And you see just basically the mineralization front, some minor smear layer, but most of it has been removed and demineralized. And you see many open tubules that are in a partial stage of being demineralized. And when you look carefully at the dentinal tubules, you'll see that still a lot of the peritubular dentin is still present and it has not been demineralized. Now, when we go to area 4, which is kind of the mid-root area, when you go into the site and go to the collage and look kind of in the mid-root area, that's the area that I've outlined in the yellow box there, you get kind of an intermediate understanding of what's going on. So when you actually zoom into this area, and it's worth your while to go into these images and move around and really see what you can observe. So you see a relatively clean dentinal surface, and then when you go into the higher mags, you can see it's been partially demineralized, no real dentinal tubules anywhere, but you get a sense for a yeast infection on the tooth. You see these structures that I'm calling a yeast infection, probably candida, but not a massive infection like more apically. You see some bacterial morphotypes there. But these are definitely yeasts. So it raises the question of why we had this particular pattern of bone loss. And when you look at these pictures, you wonder if maybe the apical lesion was responsible by the yeast infection, but maybe there's something else going on here. Either there was a fracture and I didn't detect it, or there's another etiology here, maybe a fractured root, or maybe an occlusal problem. So I want to thank Peter for coming up and doing the narration and for submitting the case. And it's open for discussion if anyone has any ideas on what really went on here.